Labor may begin so slowly that some women are not sure if it is actually occurring or not. During the first phase of labor, cervical dilation increases from 0 to 3 centimeters, and the resulting contractions are mildly palpable. Many women compare them to menstrual cramps. It is in the second stage of labor, when contractions become stronger and stronger, that most women begin to experience a level of pain for which they want to implement pain control techniques or medications. With every uterine contraction, pain receptors in the uterus are stimulated. Contractions push blood out of the myometrium and into the maternal bloodstream, which causes myometrial hypoxia and pain. The common response to pain is fear, which causes the woman to tighten the large muscles in her shoulders and extremities. This further reduces the oxygenated blood available to the uterine muscle, and contractions become even more uncomfortable as well as less effective. If the mother tightens her abdominal muscles, the uterus is forced upward against them, also causing pain. Other causes of discomfort during labor include cervical stretching and dilation, distension of the lower uterine segment, and pressure on the pelvic nerves, as well as the traction on supporting structures and the stretching of the pelvic floor. While some women are able to maintain control over their pain during labor and delivery without the use of medication, others cannot. Most women describe labor as painful. In fact, many women call their contractions pains. The pain associated with labor is related to normal muscular function, but is still a source of distress for the patient and extremely fatiguing. The amount of muscular function performed by the uterus to push the baby out has been compared to that of a marathon runner's muscles when running. When a laboring mother's muscles are working hard, they may become hypoxic, and dehydration may occur that leads to hypovolemia if fluids are not replenished. Therefore, providing hydration through oral fluids or IV supplementation and allowing rest between contractions helps maintain physiologic homeostasis and assists in pain management as well. For many women, non-pharmacologic methods of pain control can be very effective. These methods work to decrease the patient's perception of pain through the use of relaxation techniques. These are most effective when the patient has attended childbirth preparation classes and had the opportunity to learn and practice the techniques with her birth partner prior to the onset of labor. However, even learned in the more stressful environment of active labor, these techniques can be very beneficial. Slow abdominal breathing while focusing on a visual point is commonly used during the second phase of labor. Another technique is for the birth partner to observe for body tensing during contractions and lightly touch the tense area. The mother responds by consciously relaxing that muscle group. Both the act of relaxation and the change of focus away from the contracting uterus assist in control of her pain. Warm water is very relaxing for tense muscles, and the nurse may place the mother in a whirlpool, soak tub, or shower. Many women find this significantly reduces their discomfort. Massaging the mother's neck, shoulders, arms, and back can be very helpful. For some, counterpressure offers significant distraction away from the uterine contractions. In this technique, pressure is exerted on another muscle group with a fist or tennis ball during the contraction. Effleurage, a feather-light massage, can help release tense muscles and can also be performed on the abdomen during contractions. Other distraction techniques, such as watching a funny movie or listening to calming music, are often helpful during the earlier stages of labor, but cease to provide sufficient comfort or distraction as labor increases in intensity. The role of the birth partner is an important one because it gives the mother someone whose only focus is her comfort. While the nurse is often good at providing support, she must also attend to all the other details of patient care. This support is also therapeutic for the birth partner, reaffirming the ongoing relationship between the partner and the mother and child. Studies have shown that women who have both their significant other and an additional support woman have an easier time in labor, use less medication for pain, and have fewer C-sections. Known as doulas, these women are knowledgeable about the birthing process and are able to provide ongoing support for both the mother and her partner.
Very valuable, like for inducing you.
Medication and regional anesthesia are commonly used to assist women with the discomfort of labor. It is important for both the nurse and the patient to be aware of how analgesics can affect the progress of labor. Opioid analgesics tend to slow the frequency of contractions, which may cause labor to last longer. However, for some patients, the reduction in discomfort allows them to relax, which can help them work more effectively with the contractions, and labor is in fact shortened. Narcotics such as morphine, butorphanol, malbufine, fentanyl, and sufentanil increase the woman's ability to tolerate discomfort. It is important to note that these medications can cause drowsiness in both the mother and the neonate, and the fetal heartbeat variability may be blunted, requiring dosage adjustments. However, any sedating effects on the newborn can be immediately reversed with the administration of naloxone, making narcotics relatively safe for use in labor. While opioids work directly on pain receptors to reduce the perception of pain, barbiturates such as phenobarbital and secobarbital cause sedation and reduction in muscular and emotional tension. These effects can allow the mother to rest between contractions, preserving her energy over a longer span of time. However, barbiturates can suppress maternal respirations and compromise placental oxygen, and if given too close to the delivery can result in a sedated, flaccid infant who is reluctant to breathe. Tranquilizers such as hydroxyzine and promethazine act as anti-anxiety agents, provide muscle relaxation, potentiate the action of narcotic drugs, and have anti-emetic properties. Tranquilizers may also decrease fetal heart rate variability. Because they do not provide direct pain relief, tranquilizers are most effective when administered in conjunction with a pain control drug. Tranquilizers are relatively short-acting. Naloxone does not reverse the effects of barbiturates or tranquilizers. The use of regional anesthesia for pain control in labor has grown rapidly in recent decades, and the most common is the epidural block. In the epidural procedure, a local anesthetic, an opioid analgesic, or a combination of the two is injected into the epidural space. The nerve impulses leaving the spinal cord are blocked, and the entire pelvis and lower extremities are affected. The epidural space lies between the spinal column and the outer spinal membrane called the dura mater. It is important that the mother be adequately hydrated prior to receiving the epidural block. Commonly, the patient receives a fluid bolus of 500 to 1,000 milliliters of non-glucose IV fluid prior to placement of the epidural. Immediately prior to placement, the nurse positions her as requested by the anesthesiologist. Once the catheter has been placed, the anesthesiologist administers a test dose of the medication. The nurse observes for any unfavorable reaction, and if none occurs, the patient can be repositioned more comfortably. Patients are often comfortable on their backs in a semi-recumbent position. When the patient is in this position, the nurse must put a wedge under one hip to keep the weight of the uterus off the mother's great vessels so that blood flow to the placenta is not impaired. Maternal respirations and blood pressure are checked every 2 to 3 minutes for the first 15 minutes, then every 5 minutes for the next 15 minutes. The nurse also assists the patient to change positions at least every 30 minutes for the first hour, and then is needed to help the baby rotate and descend through the birth canal. Repositioning also helps the effects of the epidural to remain evenly distributed. Ideally, the medications given provide pain control while still allowing the woman to move her legs and to push effectively when the time comes. It is important that the nurse assess the patient's bladder for distension at regular intervals, as the epidural block will prevent her from perceiving the urge to void. Some women will need a Foley catheter placed, but this is removed before it is time to push. Many women are able to sleep through contractions with the epidural block in place. Depending on the medication, dose, and duration, the effects on the fetus are usually minimal with this type of pain management. On occasion, however, epidural anesthesia may affect the mother's blood pressure or uterine blood flow, causing fetal distress. This will usually become apparent during the first 30 minutes when the mother is being closely monitored, but regular observation of the fetal tracing must continue throughout the labor. Another type of regional anesthesia used in obstetrics is the intrathecal block. The difference between an epidural and an intrathecal block is the catheter tip placement. The intrathecal space lies within the dura mater and is filled with cerebral spinal fluid. An intrathecal block is usually used when cervical dilation is about 5 centimeters. It provides effective pain relief, but without the complete numbness that is usual from an epidural block. It is not used in labor as commonly as the epidural block. The benefit of this procedure over the epidural block is that it allows the woman to move about and even ambulate during labor. Side effects of the intrathecal block may include pruritus, nausea and vomiting, and urinary retention. Post-procedure monitoring is the same as that for an epidural block.